All right. Thank you very much for the invitation, and it's a great honor to be invited to present in this forum. I entitled my case the Triple Aim, and this is, as the title shows, a case of multiple simultaneous arterial and venous thrombi. So this is a case of a 67-year-old male who presented to our hospital from an outlying community hospital, complaining of a left arm numbness and tingling that started pretty abruptly at 10 a.m. while he was attending church. It progressed to excruciating pain in that arm with complete loss of motor function of the left hand and also most of the arm. He had spinal surgery before this about 2 weeks ago, and he noticed about a week ago that he was getting progressively short of breath on walking, and at the point he presented to us, he was getting short of breath even with minimal exertion and even at rest. His previous history is remarkable for the fact that he had a deep vein thrombosis after a knee surgery that occurred 3 years before this. He had been on Coumadin for 6 months afterwards and then was stopped. The patient also states that he had a, quote, hole in the heart for several years. He was followed by an outside cardiologist who decided that the respective defect was, quote, too small to repair. He had a CT scan done in the emergency room that showed extensive and bilateral pulmonary emboli, one in each main pulmonary artery. The left arm on examination was very cold. I couldn't feel any pulse in the left brachial or left radial or left axillary for that matter. He was unable to grip or use his left hand at all. He had complete anesthesia of the whole left arm. So our clinical diagnosis was recurrent deep vein thrombosis, which was complicated by bilateral submassive pulmonary emboli and paradoxical embolization to the left arm via either an atrial septal defect or a PFO. So this was our first angiogram. We took thoracic angiogram to define the exact location of his arterial thrombosis. As you can see, this type 1 arch, the thoracic aorta is patent. There is a filling defect in the left subclavian, which we can define further in the distal left subclavian, consistent with an acute thrombus. So how to manage these concomitant conditions? Two submassive PEs and an acute upper extremity limb ischemia is, we thought, an interesting clinical question. So you could choose systemic anticoagulation or medical therapy, but this would be likely ineffective, and he clearly has a high risk of limb loss. One could choose also systemic intravenous thrombolysis, but he clearly has a contraindication pretty major due to his recent spinal surgery, and this would also raise the risk of bleeding if subsequent arterial intervention was needed. In order to help us with decision making, we also did the right heart catheterization. His RV pressure was 57 systolic. His PA pressure was 60/22 with a mean of 38, indicating at least moderate pulmonary hypertension. I didn't measure a wedge because I didn't want to lodge my catheter into thrombus. So what we decided to do in the end was to place 3 catheters, one in each main pulmonary artery and one selectively into the distal left subclavian artery, and infuse TPA through each of them. So the patient stayed in the ICU overnight. His coagulation parameters, CBC, PTT, and the dimers were monitored carefully every 2 hours. He did well. He didn't have any major bleeding complications. His neurological status was intact overnight. The next day angiogram shows resolution of the distal left subclavian thrombus, but still remaining significant thrombus burden in the left axillary and no significant flow beyond this point, with only some minimal collaterals around that. So I decided at that point that mechanical intervention was needed. Therefore, I chose a Penumbra device, an 8 French Indigo device. I performed thrombectomy of the proximal brachial artery, which was successful. Then I downsized to a 6 French CAT Indigo device and performed prolonged thrombectomy in the distal brachial artery, and then advanced it also with the same catheter in the proximal radial artery. During this case, I injected a total TPA dose of 10 milligrams in addition to his overnight thrombolysis. So here's a review of the Penumbra Indigo system. Most people may be familiar with the system. This is a mechanical thrombectomy system that's based on continuous aspiration. It's composed of a canister, a pump, and a suction catheter. It has a separator wire, which is used to prevent clogging of the catheter. And the main sizes used for peripheral applications are 8, 6, 5, and 3 French. So these are the results after thrombectomy. I don't have any cines, but the flow was excellent through these. So you have complete recanalization of the distal left brachial artery as well as the ulnar artery. There's some spasm of the right radial artery. Maybe the thrombectomy catheter was a little bit oversized in that, but there's excellent flow in the radial and actually excellent flow in the palmar arch and all the way into the distal arteries to the tips of his fingers. So this is a montage showing the before and after angiographic pictures, as well as the thrombotic material that was retrieved from his distal axillary artery, as well as brachial artery and radial artery. So there's quite a significant amount of thrombus. So how did the patient do? He was placed on Eliquis and aspirin in the hospital. He had a few episodes of paroxysmal atrial flutter, which necessitated a little bit prolonged hospitalization, and he was started on intravenous amiodarone. He stabilized, and he was discharged home in 72 hours after his procedure with intensive physical therapy for his hand. So on clinical follow-up, transesophageal echocardiogram performed by us revealed what we suspected, that the patient had a significant secundum ISD. He actually underwent successful ASD repair with placement of amplifier device 1 month later at OU by Mazen, who was here in the audience. The device was well seated. He had no residual shunt on echo after 3 months on follow-up, and I saw him follow up 3 and 7 months later. His hand function had completely recovered. He had bounding radial pulse, and he had no clinical recurrence.
That's a great case, Ivan. I was wondering, when he came in, was his head CT negative? I mean, he's kind of lucky just to send that thrombus to his brachial and not his brain. And obviously that plays into the fact of how are you going to treat this guy. So, and then my second question is, did you just drip it, or did you cross it and drip it? Did you put the unifuels into the clot? Because I think one of the things for the fellows is to make sure if you just drip it beforehand, it doesn't do anything. You got to get through it with a wire and drop the catheter right into a metal clot.
Those are very good points, both of them. So on the first one, he was neurologically intact, although he could not move his left hand, but we thought this was due to ischemia, not because he had a stroke.
Yeah.
So you could have done a CT scan of the head, but
I'm surprised the ER didn't
necessarily.
Like what they do, right?
Yeah.
It's all they do.
Than all the other ones. So on the catheter positioning, that's a very important point. So I always try to embed all the catheters as much as I can in the clot. So we do direct TPA infusion inside the clot. This way I can macerate them beforehand a little bit with wires or something else, but you want to have the TPA dripping in the clot so it increases effectiveness of the therapy.
One of the questions is what the timing of your mechanical thrombolysis. Certainly with your initial imaging, depending on whether or not there was any significant outflow to the arm, one might have done some mechanical thrombolysis beforehand, before the initial drip, to establish flow first, and then to do thrombolysis. Did you consider that? I didn't see any images.
I did
of the
consider
hand
that,
first.
but I thought there was just so much amount of thrombus there that I rather wanted to macerate that beforehand rather than jump into a mechanical thrombectomy.
Sure.
And I can tell you, I've had cases like that. I've had another case where we did what you're saying, and it didn't end up so well.
What about a filter?
Filter.
That might be a situation to put a filter down in the brachial and do some of that indigo stuff upstream to that and protect an embolization.
Yeah, unfortunately, with the Penumbra, you can do that very well with an angiojet, but with the Penumbra, you really can't use that because you have to use the separator in there to allow for patency of
unless you use
so that's the
two
one
arterial
downside
access sites.
One of the, so if you use, just as a thing, you can actually use a separator wire and the filter wire in the same place. It's just one of the things that,
I haven't tried that.
If you have a high embolic burden potential, then you can actually use a filter if the wire goes through the CAT with the separator wire from one of the smaller CAT devices. Just a consideration.
I'm quite enthusiastic about using filters in most of these scenarios, but I haven't thought about that.
I think one thing for the fellows just to pay attention to is that obviously you got a guy who's presenting with acute limb ischemia of his hand. It's a dangerous situation, so you want to make certain that your surgeons are on board with you as well. This patient could have reperfusion edema, reperfusion compartment syndrome. We'll see that in the leg. You don't obviously see a lot of these up in the arm very often, but this can be a remarkable situation. You want to make certain that the patient doesn't have permanent neurological injury. And time is of the essence here. That's why I probably would have done what Tom said. I would have probably dropped a filter, gotten some sort of flow down there, and then dropped either an ECOS or a TPA Unifuse or something just to get some flow, to get some sort of muscle back. I would hate to leave this guy with pain for 24 hours. How were you able to control it, or how did he go?
You know, he didn't have pain. The anesthesia, the fact he had anesthesia helped.
Okay.
I was a little bit loath to upsize his sheet and then leave him overnight with TPA infusion going, although it can be done.
Obviously, you made the right decisions.
Yeah, he's doing great.
Good outcome, really good outcome.
Great, awesome. Thanks so much.
Started with angiojet, or were you considered ballooning at all, or how to filter down balloon?
Tom, how would you have done it?
You know, it depends. I think that for thrombolysis to work with TPA or the ECOS, you have to have some flow. And so if there wasn't any flow, if that was a flush occlusion with very little distal runoff, then I would have done some thrombolysis, probably with the Indigo system. I would have used a Penumbra up front with a filter just to get some of that debulked, and then done TPA afterwards is an option. But clearly, you probably had some flow in there. You felt that and it could be that the TPA softened enough to let the Penumbra do its job. Sometimes maybe if you wouldn't have done that, you wouldn't have got any suction out of there. So,
you know, on these cases, both in the legs and in the arms, I've had much better success dripping TPA overnight and then removing things on block or with angiojet or some kind of mechanical device, rather than trying to be very aggressive at the front end and then.
And it all depends on the age of the clot, right? So if you have a very fresh clot, that usually lyses with whatever you do.
Right.
Intermediate age clot to me is 7 to 21 days. That stuff usually requires a little more work. And from looking at that, that looked like a clot that probably was in the leg for a while.
Exactly.
That went across.
Exactly. Yeah.
It was probably 2 weeks from his pre-surgery. I probably would have gotten some flow, maybe tried some with an angiojet, and then I would have just left it and dripped it. Dripped it or put in ECOS, whatever you want to do.
Yeah, so we have according to our protocols, 0.75 for 6 hours, and then you can, depending on the scenario, you can continue after that up to 10 hours or 12 hours.
Yeah, that's one of those ways. You got 3 catheters dripping TPA. You probably stay in bed, don't move. Any headaches?
I would have done that case just like you did, because you had a really good outcome. So good job.
Awesome. Who's on this one?
Okay.
Let's see. It's great to see some venous work here. I was complimenting Aaron on. It's great to see the interventional cardiology community ingesting and kind of embracing this idea of it's an area that really needs to be done, especially for the QPE and the acute DVT.
Can I ask you a quick question for this one starts?
Yep.
My institution, we just started treating PEs, cath lab, and initially started with ECOS, trialing it, worked great, and then financial institution pushed back on reimbursement a lot. So we've now basically had a withdrawal. ECOS, I'm surprised there's not I don't want these now Unifuse since.
So there's the ongoing Sunset trial, which will.
Why is there not a randomized trial?
So the ongoing Sunset trial will answer this question. This is randomized ECOS versus Unifuse. So it's enrolling right now. I believe it's out of the University of Pittsburgh, and so we'll have an answer. I mean, I think you got to obviously get some financial buy-in. I think the PERC consortium and Kenny Rosenfeld's work up in MGH has been fundamental. And if you look at the data, I think we're looking at cost effectiveness. That's the thing that we really want to look at, because they are expensive catheters, no doubt. It is impressive to me how well they work, especially when you drop them on the arterial system. Like if you use them in acute limb ischemia on the arterial system, how well ECOS. Yeah, I mean, it's amazing.
The results are fantastic that we had.
But the cost.
I've only done one with Unifuse, so I don't know if it will be really that much different.
Well, the only thing I would say, if you want to make it financially to your advantage, you have to use the ECOS as it's intended to be used. You use less TPA and you use it for less amount of time. So we usually do these cases as early as possible in the day. Instead of dripping 24 hours in the Unifuse, we actually bring them back to the cath lab in the afternoon, or if we do them late afternoon, we bring them first thing back in the morning. So their ICU stays is less, you save some money there, and that's how you can make a difference. If you're going to use it exactly the same way you use the unifuse, there's no advantage if they're going to stay in the ICU for 2 days.
You want to use the optimized PE
Right.
protocol, 6 hours,
Yeah.
though there's no, I mean, that data shows at least some benefit about a short and abbreviated. So TPA is very expensive in addition. So if you can use it, higher dose, maybe early, shorter duration, get them out of the ICUs, that's going to save your hospital more money. And I know, I forget which group it has as a cost effectiveness study ongoing, looking at keeping patients in the ICU versus obviously getting them rapidly out to the floor and rapid discharge. And that's that's how you can push back to the hospital and say, we'll make
Our
money.
concern with it was that ECOS has the FDA approval for TB and LP use. Or is it off-label to be used in that?
I think it's for thrombosis of a vessel. So it is, quote unquote, on label, but it doesn't tell you which vessel. So it is